you.
Good to go?
Yeah.
Good to go. Good morning, everyone. My name is Amy Allen. I'm the Vice President of the Westchester County Association, and I'm delighted to welcome you to our Life Science Spotlight program entitled An Ounce of Prevention, Challenges to Innovating in Preventative Healthcare. For those of you who don't know us, the Westchester County Association focuses on issues and initiatives that drive our regional economy, and none is more important than our healthcare and life science sector. Quantitatively, it is by far the largest economic engine in our region, and from a qualitative perspective, there is no work more important than improving our collective health and well-being. Westchester is home to leading academic medical systems and a growing life sciences industry. That's a powerful combination with great potential for collaborative research between clinicians, researchers, and life science companies. And events like these shine a spotlight on Westchester's leading role, helping to create new opportunities to drive scientific and medical breakthroughs and economic growth. As we know, innovations in healthcare that target prevention improve patients' quality of life and can potentially save money as well. However, developing and funding these innovations can be challenging. Fortunately for us, our distinguished panel will sort through how to navigate those challenges. The Westchester County Association is delighted to partner with the County Office of Economic Development and the Westchester County Biosciences Accelerator to bring you today's program. You'll hear from Deborah Novick, Director of Innovation for the county, later in the program, and I also want to recognize Bridget Gibbons, the county's Director of Economic Development, who is here with us back there in the back. Hi, Bridget. I also want to acknowledge and thank the sponsors for today, and you can find them listed on the back of your programs. Westchester County has long recognized the life science sector as a key component of its economic development strategy. And here to speak to that on behalf of the county is Deputy County Executive Ken Jenkins. I think I have to give you this. Hi, Ken. How are you?
Oh, good morning.
There we go.
Sorry about that.
No problem.
All right. Do I need this? No? Okay, good. Good morning, everyone. It's certainly a privilege to be here with you this morning as we talk about this very, very innovative sector, and more importantly, the opportunity to hear some more from this distinguished panel. It is a privilege for us to have partnered with the Westchester County Association and first-time founders to have this kind of opportunity to talk about funding and, more importantly, how we deal with the ounce of prevention and the business case that needs to be made for the preventative side. Because in our Accelerator program, and first-time founders have done a fantastic job, and through that program, we've had 41 different founders come through that life sciences program. And the challenge continues to be who's going to fund and how we're going to support the preventative side. Because it is always talked about curing, but the prevention, and I heard this from my mom once or something, an ounce of prevention is worth a pound of cure. And I think that this kind of opportunity today is that kind of thing to continue as we walk forward in the life sciences, because it's a priority area, as Amy pointed out, for Westchester County and our Office of Economic Development, and for all of us to continue to move forward. So there's over 200 other entities in Westchester County that deal with life sciences. We think of course, we think about the big dog when we think about Regeneron. But we have so many other partners to do that. So this kind of opportunity today to hear from our partners here in the panel and working with you is the way that we can continue to move this forward. So Westchester County is always proud to partner with not just our friends at the Westchester County Association, but with our first-time founder leader in this endeavor. So we are welcoming you today, and we certainly want to have this opportunity to continue to move forward for Westchester County. And thank you for all taking your time to be here this morning. Have a great day.
Thanks, Ken. All right, I'm going to take a page from Ken's book. Can you hear me? Thanks, Ken. Actually, now this part, it's time for me to turn over the hard part of the program to our moderator, Mary Howard. Mary is the principal of FirstX founder and the program director of the Westchester County Biosciences Accelerator. Mary will introduce our panelists and take it from here.
Thank you, Amy. We love working with Amy and the Westchester County, the council, they have fantastic programs, and in fact, this event was inspired by an event that Amy had last February. So we are here today to talk about an important issue. We're going to start and jump into this because it's a very complex, big topic, and we have some background to give in terms of sharing how we're going to look at prevention, because it really touches everything. As Deputy County Commissioner talked about, an ounce of prevention is worth a pound of cure. Ben Franklin talked about that from Philadelphia when he was seeing the improved process that they had to prevent fires, which was a huge problem in the 1700s in towns that were being built. And he wanted Philadelphia to model their fire prevention activities on what he saw in Boston. We are in a situation where there are many things to learn from many people about prevention. And one of them is, as everyone has always faced, is that prevention is expensive. And there are a lot of people who are healthy appearing, and they may not be either interested in prevention, or it may not seem like such a critical issue. So we understand that there are some problems with that underlying addressing prevention. We want to create a little bit of a context about what we're talking about here. From a medical perspective, the natural history of a disease classifies it into 5 stages, and alongside each disease stage are associated prevention measures. The first stage, underlying, those prevention measures often end up being children-focused. And there are things like building a sidewalk to reduce risk factors down the road for obesity, diabetes, cardiovascular disease, reducing or limiting tobacco advertising, and taxing tobacco. When you get into the next disease stage of being susceptible, that's considered a primary prevention. And the purpose there is to prevent a disease from occurring in a healthy appearing individual. So that would be vaccinations, which we've had a lot of in the last couple of years, but also things like tobacco cessation programs and also needle exchange programs. When you get to the next disease stage, you're talking about subclinical with prevention at the secondary level, and those are, again, dealing with healthy appearing individuals, and a lot of these are diagnostics like pap smears to prevent cervical cancer, mammograms for early detection of breast cancer, blood pressure screening. We then move on to the 4th stage of a disease, a clinical stage, and tertiary prevention, where we're talking about targeting clinical and outcome stage of disease to reduce the effect of the disease. So I think for a lot of what we see as medical innovation, it's in this area where there may be rehab, there may be, and we know there's some people in the audience who are directly innovating in this field, occupational and physical therapy in burn patients, people who are pursuing diabetic foot care. And then in the 5th stage of a disease, recovery, disability, and death, these are efforts in prevention to prevent having excessive medical interventions. Some of these create more harm than good. And we think about some of the excess exposure to radiology and some of the challenges that can arise from that. So we are not going to cover everything here. We've got a half hour. So what we're going to address here, we've specifically decided to kick off this conversation with representatives from government, and we have online from Finland a cardiovascular MD who is the head of exercise in the central county of Finland to talk about how that works there. So this is very early stage prevention, and as New York is a leader in prevention and in healthcare availability, we're interested in learning from all over the world and have invited Mirja Peronin to join us. Here locally, Andrea Safarelli from New York Blood Center is here. She's going to talk about an established set of products and services in prevention and the great work that they are doing to spur innovation for blood diseases. We also have hospitals here represented by Michael Latchman Singh. Michael is the head of innovation at White Plains Hospital, part of the Montefiore system. He's also running the venture fund there at so there is a number of different aspects that Michael has to cover in terms of considering what prevention to pursue. And finally, Sylvia Codnoy, who's here from New York Ventures, a venture fund which is looking at New York innovation and what to fund. So she has seen many, many different applications, including from the Westchester County Biosciences Accelerator program, and to share some of her perspective on, what can you fund from a private investor standpoint in innovation. So we want to kick this off. We've got some introductions to this. We want to pursue having some of the people who are involved in this and have been supporting of this, thanking our sponsors, which have you seen, and Amy and Ken, and we want to just start with Andrea. And Andrea, I'm going to advance the slides, and we have a recording going on, so Andrea, if you can just speak into the mic so your voice could be captured as this is being recorded, that'd be great.
So thank you so much for having me. I'll talk a little bit about New York Blood Center because I feel like we're the best kept secret, probably not our core business, which is that we provide 1 million blood and blood products to about 35 states across the United States and several foreign countries. We were also the largest producer of convalescent plasma, produced to 42 U.S. states and 4 foreign countries as one of the early treatments for COVID. But we also have a huge research institute with 19 researchers. We're also big on training the next generation, and we are taking over the Rye former Avon facility for our first ever campus. So we operate several blood centers across the country. The blood industry, small blood centers, just were struggling to survive, so we sort of gobbled them up, and we have a network across the country, and you can see those. But we also have a ventures fund, we have Comprehensive Cell Solutions, our National Center for Blood Group Genomics, our cord blood program, and as I said, our research institute. Our scope, as I spoke, we provide products and services all across the U.S. And a tremendous amount of partnerships. Our impact, so we serve a community of about 75 million, about 400 hospitals, 500 million in revenue, and as a not-for-profit, that collecting blood, we actually do it as at a loss, that people don't really realize that. And so you can see kind of our scope. We're super excited, most excited about our Rye campus. So it's a 187,000 square foot building that we expect to open in probably September of next year. So not only will it do our blood and blood processing and delivery, but it will have a state-of-the-art donor center for cellular collections as well. Our researchers will be moving here from our building in New York City because we also have plans for that building. And we're growing our comprehensive cell solutions and regenerative medicine and cellular therapy portion of our business, and that will all be at the Rye facility. If anyone wants a tour, we would love to host you. Next. So our Center East, what we call our Center East Life Science Hub, is our headquarters and has been for 60 years. And We're almost through the process for approvals to go 13 floors up for a biotech incubator type space in New York City. So our investment in the biotech and regenerative cellular therapy, gene therapy space is evident in our 2 buildings. The next is our products and services. I won't bore you with all of that, but what's really interesting is we not only provide blood and blood products for patients, but we also do partnerships with researchers. So we have the source materials for people that are researching and trying to come up with new therapies. Our researchers, we do HIV, dengue fever, river blindness, malaria, leukemia, all kinds of research, benign hematology, regenerator cells. So we have 19 investigators all right now in New York City, and they're looking forward to being at RAI. Our comprehensive cell solution business, we just acquired 2 facilities, one in Kentucky and one in Texas, and that business is really growing as well. And that's it. I'll pass on.
Thank you. Thank you very much. What we'd like to do is go ahead, Michael, if you can give some background on White Plains Hospital and what you're doing.
Absolutely. Hi. My name is Michael Achman-Singh. I'm the Director of Innovation for White Plains Hospital, as well as the Director of East Post Road Ventures, the investment arm of White Plains Hospital. For anyone who doesn't know, really, the high level and briefly, White Plains Hospital has been serving the White Plains and greater Westchester community since technically since the late 1800s. As recently as I have data, we're probably serving around 75,000 ED visits annually, over 25,000 scheduled surgical visits, and if you include ambulatory visits across it's constantly growing, so this number may not be accurate, but I'm going to say 41 practices. We probably touch around 500,000 Westchester residents a year, if not more. The venture fund has been around only about 4 years, though. It was created to facilitate a relationship where solutions to the organization's pain points and opportunities to improve would be co-owned as sort of partnerships rather than just these traditional vendor relationships. And what's come out of that is a pretty robust portfolio of about a dozen companies that we're doing some really interesting things with that I'll jump into later. But that's in a nutshell what White Plains Hospital and East Post Road Ventures is doing.
Thank you, Michael. Sylvia?
Hello, I'm Sylvia Codoni from New York Ventures. So we are the venture capital arm of the New York State. We basically do investments directly into companies that are based in the state and are venture backable. We always invest together with other private investors. We also have an emerging managers fund where we invest in emerging managers in the VC space. Our general mission is to close gaps in access to venture capital. That's why we are focused on 3 main gaps: underrepresented founders, underserved geographies, and areas that require deep capital, typically deep tech or a lot of things that require a lot of research or resources before they are actually viable. Life science healthcare is one of our main verticals and is something that's close to my heart since I've come from this business, having done drug development, devices, and digital health before being an investor.
Super. Thank you very much, Sylvia. Now, we did not bring Mirja Peronen from Finland. So we're bringing her to you on the screen. And Mirja will share some of her background and what she's been working on. Thank you, Mirja.
Yeah. Hello, everybody. I'm Merja Perhonen, and I'm from Finland, and I will send you very cold wishes from here. We have freezing temperatures, minus 15 centigrade, so I think you have much better there. I'm a specialist in exercise medicine, but I have done quite a lot of research on cardiovascular medicine in the US. I did my 2 postdocs, first in Chicago for 2 years and then 3 years in Dallas, Texas. And in Dallas, I was conducting a research which was sponsored by NASA. So I have quite a lot of experience from the US as a Finn, but I haven't been living in the US for 3 years since I made a 2-year visit in the US some years ago, and that's why we know each other with Mary. So I'm telling you about the exercise medicine clinic, what we have in a public hospital in Finland. And of course, in Finland, everything is public, but this kind of a clinic can be run also in a private sector, in a private clinic. But we run it in a public, and we don't need to care about fundings because this is government-based. But of course, in the US, for instance, the insurance companies might be interested in this kind of program. So this exercise medicine clinic was started in 2016, and I was the one who was taking care of the whole thing in the hospital. This is the first and only exercise medicine outpatient clinic in a public hospital in Finland, and we will try to spread this around Finland mainly next year. We wanted to spread this earlier, but these COVID years were hard for everybody, and we weren't able to do this at that time. It's a small clinic. I'm the chief physician, and we have 2 residents and 2 physical therapists. But it's very interesting that we have got a lot of respect from other doctors in the hospital. We have the expertise in treatment of patients with exercise and lifestyle changes in the main hospital in the middle of Finland. We get referrals from other outpatient clinics in the same hospital, from other doctors, from other specialties, and most of them come from there. Then we get referrals from healthcare centers, student healthcare, occupational healthcare, private healthcare. So the main point is that we are a normal outpatient clinic in a hospital, and we need a referral from a doctor. Then we do collaboration with local towns and communities. We have 4 different care paths at our clinic, and the first and biggest one is weight management care path. And of course, in Finland, but also in the US, the overweight problem is everywhere. And we see a lot of patients with overweight, but these patients need to have some disease when they come in. So normally these patients have type 2 diabetes, coronary heart disease, knee arthritis, for instance, anxiety, depression, whatever. Everybody knows that exercise is a very good cure for almost all diseases, and it should have to be included to every care. So we see a lot of overweight patients, also underweight patients, maybe eating disorders or something like that, and we try to get them back to life. And then some people are growing number of women are overweight, and they have a desire to get pregnant, but the problem is the overweight. And then we work a lot with gynecologists to get these women lose weight and get pregnant. Then we have this exercise care path where we handle patients with fatigue, tiredness, cancer, other severe diseases. And for instance, this cancer, which is very, very hot topic everywhere, we, for instance, a woman with breast cancer is getting all the treatments what they get, and after 3 months of the treatment protocols, their physical fitness is down, and then we try to get these people back to life, back to exercise and better condition. Then we have recreational athlete care path, and there we do these stress fracture follow-ups, overtraining symptoms, follow them for a longer time to get these people out from these diseases. Then, of course, this bariatric surgery care path, it is increasing, and every patient who goes to a surgery care comes to our clinic, and we get them advice in exercise and in other lifestyle changes. And the purpose of our clinic is to do follow-ups that, for instance, for this overweight management care path, we have initial appointment and 3 follow-ups for 12 months. And for bariatric surgery care path, there is pre- and post-operative follow-ups, and for other care paths, it's as needed. We have a multi-professional collaboration, physicians, physical therapists, nutritionists, and exercise physiologists. Here I show you a poster which I presented in American College of Sports Medicine meeting last June, and here I'm presenting here the results from the patients who had sleep apnea and overweight in our clinic. The follow-up was in this study 6 months, and we actually got the results what you expect to get, but the colleagues at the meeting were very excited that we have done this kind of a study, because this is a real life or real world study. So we don't have anything like a control group. This is not a randomized control trial. This is what we do and what we get. So here you can see the main results. This is overweight patients, visceral fat. When they increased PA, it's always in blue, and in green, no increase in PA. So visceral fat went down, and the 6-minute walk test distance went up. So this is the right way, what you should have to do when you start exercising and doing lifestyle changes. And in these sleep apnea patients, you can see the same results. Then, of course, body weight, body mass index, and hand grip strength, everything improved in those who increased physical activity, although it was an overweight patient with just overweight and some other disease, and these sleep apnea patients. And here is another research study that where we had follow-up for 12 months, and only for this guidance what we do at our clinic by physicians and physical therapists, we get this kind of results. So we don't give any structured programs to do, we just guide them to do and try to find the mode of exercise what they want to do. So body weight went down about 5 kilograms, waist circumference about 5 centimeters, fat mass 4 kilograms, and visceral fat over 8%. So these all are statistically significant results. That's what is pretty interesting, is that how their physical activity changed during the 12-month follow-up. So if you, for instance, see this red one here, which is low activity level, it was 80%. After 12 months, it's only 40%. And there is this gray is high physical activity level. Here it was 4.3 and here 27%. Then this is how aerobic exercises, so endurance exercises increased decreased from 37 to 15, so that nobody didn't do anything, and those who did over 3 times a week was only 1.2 before, and after 12 months it was about 34%. And then strength training increased, and like this over 3 times it was nothing, nobody exercised over 3 times when they started, and after 12 months it was already over 6%. So these are pretty nice results what we have here, and the reason why we do this kind of research is that we are interested in research. Of course, we are trying to do papers on this, what we do, and we also need to show to our leaders in our hospital and in the whole area that we are needed in the hospital. So so far everything is going well, we do well, and I think that this would be a very nice model to implement also in the US in the private sector.
Thank you very much. We got a lot of background on that, but I think for many people it's that information is pretty unfamiliar, or that there is a commitment to this kind of work. So we want to step back and hear from our panel, which has clearly got a lot of different expertise, to hear their perspective on what are some of the problems that they're facing in prevention, and what are the easiest solutions to pursue within their organizations. So Andrea, can I have you start?
Sure. So, as I said, we're sort of the best kept secret, and folks know that we provide life-saving blood and blood products, and we don't support drug development specifically, but historically, some of our biggest accomplishments, we have patented hundreds of processes that are used worldwide. We had the first commercialized solvent detergent technology that made plasma safer. We had a first hepatitis B virus detection test, the first injectable HIV drug patented. So that's kind of our history. So where are we going forward? So the investment in our 2 buildings not only providing source material to companies that need to do further research, hopefully for new cures or therapies in transfusion medicine, but we also have 2,200 employees and expertise. And so new companies trying to find therapies can come to us, obviously for source materials and partnerships, but our scientists and our transfusion medical experts can provide a level of collaboration in our incubator space that you might not get anywhere else. One of the things we're looking at that I think is interesting is specialized medicine. So blood and blood products and transfusing patients really hasn't changed in 6 decades. If you need blood, you get it, and we match ABO. But we have a National Center for Blood Group Genomics. It's actually in Kansas City, and we're working on a fast throughput process where all blood could be genomics tested. Right now, antigen-neg blood is primarily used for sickle cell patients, and increasingly for sickle cell patients, they're pre-transfusing as opposed to waiting for crisis. And so we're very curious of whether our National Center for Genomics Testing and precision medicine is the wave of the future where, we prevent transfusion-related reactions and things like that.
Super, thank you so much. Michael?
I think framing it as the easiest opportunities in healthcare is a little bit of a paradox. I don't think, unfortunately, anything is easy in healthcare. But I will say, if the first step to prevention, let's say the first step to prevention is knowledge and the second step is access, I can share that before the recent AI craze, probably 6 months, if not a year ago or earlier, we had been doing things at White Plains Hospital in that space to help with access in ways that are, I guess, probably very chic right now, such as using AI tools to help with maximizing our ED throughput. Our ED volume is increasing year over year over year. We've made some investments in tools that help us load balance what our ED providers see so that everyone is fairly distributed with the sort of patients coming through the door. Another great example is that there are a lot of opportunities to help with access and also throughput in the radiology space. So there are AI tools that can help not only load balance the pending studies that need to be read in terms of criticality, there's even AI being developed now in terms of, I think I see something interesting here, Dr. So-and-so, you might want to take a closer look at that. And that's, believe it or not, current and even historical state for the organization. Looking into the future and what we're doing on a smaller scale, but I'd love to see grow. I don't know if you had a chance to mention it, Mary, but that fourth level of prevention is clinical prevention, I believe. Mm-hmm. And it's when someone already has an underlying disease or chronic condition, but you want to prevent it from escalating further or getting any worse. And that's where a fairly young but very robust program that White Plains Hospital offers through the strategic investments of East Post Road Ventures. It's our remote patient monitoring program. So for anyone who isn't familiar with what that is, it's almost exactly what it sounds like. It's, hey, Mr. Smith, Mrs. Jones, you have this chronic condition, heart failure, diabetes, COPD. We love you, but we don't want to see you back in the hospital, ideally ever again. So what we do is connect them to our WPH Cares team, which is part of also the hospital's access center, so that when they go home, they're sent with a blood pressure cuff, a weight scale, a pulse oximeter, and believe it or not, those devices are smart devices that connect to either a Bluetooth hub or we may move to cell-enabled devices. But we just ask that these patients hop on that scale once a day, put on that cuff once a day, take that measurement, and a group of dedicated clinicians monitors that population every single day. And so while we're never going to be able to remove the, heart failure or chronic obstructive pulmonary disease from that patient's life, we can limit its progression, ideally halt it almost entirely so that they have a much higher quality of life. Of course, where the challenges come in is in engagement and in infrastructure and some things that are outside the organization's control. But I think near current and future state, as we look to diabetes and COPD, I think there's going to be some exciting preventative measures taking place through the organization.
Thank you, Michael. Lots of innovation right here in White Plains. Sylvia, so you have a very different perspective, right? You're an investor. So what's moving forward, and what are challenges?
Yeah, so we generally, if we're thinking venture investment, right, and new startup companies that would come and have a solution of some sort of preventive solution. So the main two areas where I think are challenges is one is the business model and the other one is adoption. Because in order to be a successful company as a startup, you need to be able to monetize whatever you're doing and have a line of sight on how this is going to be paid, who's going to be paying it, and how you're actually going to make money, because that's what you need to survive as a company. And as any investor would be looking for that to exist, or a pathway to that. The other challenge as a generic thing is adoption. Anything that has to do with people changing what they normally do and is hard. And that is one aspect of the adoption. The other aspect of adoption can be from hospitals, right? Those are big organizations, complex organizations. If you want to insert something new, Michael is saying yes, it requires a lot of work, right? And sometimes we might think, oh, I have this new idea or new solution that is going to be good for patients. How come they're not going to adopt it? Well, it's not that they don't care about it. It's just that it's not so simple. And they need to put, even when you say, I'm going to do a pilot and it's free for the hospital, well, it's not completely free, right? Because they need to put resources to it. I think Michael can comment on that afterwards. So these two things are, I think, the two themes that are relevant. Also, in terms of adoption, can be another aspect of the whole prevention is even access to care. I think where we have seen and have successful companies in our portfolio that was maybe a good example on how we could see it happening was more on health equity and access to health, which is also ultimately a prevention, right? The people not having access to care is the first thing we should fix. So we do have one of our companies in portfolios exactly about that, on helping federally qualified healthcare clinics to do better. They basically take away all the administrative stuff and they allow them to do value-based care, and that opens up a whole suite of people that now can take care, preventive care included or normal care included.
Super, thank you very much. We'll come back to you, Michael. Mirja, you want to add anything about, you've sort of solved the access problem by having government fund everything, but how about adoption? You've talked about the number of people who are overweight and suffering from diseases that, as you're very familiar with in the United States, cause chronic conditions. Your statistics are incredible about people actually, after 12 months, being stronger and actually exercising. And, are there challenges in that adoption that you're seeing, even when you remove the access issue? I'm not sure Mirja is able to hear this.
Are you calling?
Yeah, Mirja.
Yeah.
Yes, please.
So I was these fitness centers are spread all over US, and it's quite a good business, I think so. So I was wondering if this same kind of a model could be used for this kind of clinic or center or whatever you would like to have for patients with chronic diseases, because they would benefit it a lot. And if the doctors, or actually the doctors know that they should have to do lifestyle changes and exercise to get better results in the treatments. Also, the medication could work better if you do these changes. So you have a lot of professionals in the US. You have physical therapists, exercise physiologists, you have behavior change specialists, everything there who could do this kind of a job in collaboration with the doctors and nurses. So I don't know what else I could suggest here. I couldn't hear your talk that well because it's if you look at me, so I can because you are looking now to another direction, so I can't see you.
Okay.
See you.
Okay.
Yeah.
Thank you, Mircea. If you hadn't guessed, Mircea is also an entrepreneur. So here in Westchester, Michael and also Sylvia, you know, this is already solving for the U.S. version of the problem, right? You know, it's so impressive to be with people who can be in two different cultures. So let us come back to this and talk about the issue, Michael, that was brought up by Sylvia. Do you want to comment on some of what she discussed as far as the hospital adoption and the patient follow-up?
Absolutely. And by the way, even if gyms were free, I question the adoption rate, unfortunately. It's just the nature of exercise and human beings. So Sylvia was alluding to it, and it's completely hits the nail on the head. We try to build these programs and these pilots to be as accessible as possible, but there's always that combination of not knowing what you don't know and taking certain things as assumptions that you're not even aware of because of your own personal circumstances or biases. So a perfect example, I would argue that we're in a sort of V2 or Mark II of our remote patient monitoring program, and it's going quite well for our heart failure population, where we're helping keep folks home and safe and comfortable and preventing disease progression, which is phenomenal. But in V1, which also coincided with COVID, which was yet another factor that added complexity to deployment, we were initially working with one of our portfolio companies through East Post Road Ventures, and still are as our solution for remote patient monitoring. They provided the platform. Well, how are these devices going to connect to transmit data every day so you know how your patients are doing? Well, initially the solution was going to be, we have an app for that. That's easy. Everyone has a smartphone, right? Everyone knows how to use their smartphone, right? Well, in practicality, what we learned and what was interesting from many, many personal trips to the bedside is Mrs. Smith, who may be 62 or 82, the Venn diagram of folks who have heart failure and the overlapping circle of folks who know their iTunes password is very, very slim. So what ended up happening is, let me get my daughter or my son on the line, let me help get some help with getting this password done. And it, of course, made the process of adoption more time-consuming, and it also created these self-selection biases where it's like, that's interesting. Our remote patient monitoring population happens to be and I think it was, Caucasian women from the greater Westchester area, around 85 years old, whatever it was. So that was a hard lesson learned, and ultimately what the solution ended up being is how do we remove technology as the barrier and allow it to be the solution that it is. At some marginal additional cost, we invested in something known as a Stel Hub, and it effectively just turns all of your devices into Wi-Fi enabled devices that automatically collect the data. So as long as there's power in your home, you plug this little magic box in, step on your scales, use your blood pressure monitoring system, and the team can monitor you effectively. So that ended up being the solution. It required an additional capital investment, but it was not contemplated when we were sort of mapping out the initial workflows for deployment. So even that radically changed both our adoption rate as well as the diversity of access to patients who could now participate in the program. So that was a big lesson learned.
Super. We're at the early stages of all of this, right? There are two cases. Sylvia, I'd love to hear from you about how you've handled it from an investment standpoint, where there's, with some rehab products, the costs just aren't that much to buy them. There's not remarkable revenue that people generate. There's not remarkable profits. But there could be an impact. While people have a hard time with the idea of exercise, as Michael explained, we also know that 10% of statin medications or only 10% are being used. So there's a big problem here with compliance in kind of every area. So how do you address either a not very costly solution providing a big benefit and these behavior changes when you're thinking about business models and investing in people's ideas?
Yeah, this is a hard one, right? And really, it becomes what is a creative solution for it, because you need to then find enough volume, right? So things can be a partnership with somebody or some institutions or so that does have this way to push it or to share it. You might need to be more of a marketing machine for it, right? So your business model changes and what you need to succeed changes on those things. And for on the flip side, what you would be looking for is there is distraction and there is this difference on how you're going to approach it. The praying part of it will not exist, right? You cannot. You need to see a line of sight on how this is going to be accomplished. And probably is something different. I'm also, the hard part, right, is that we don't have a model we can copy. So when you see something that has a big impact, says, wow, this would be great. Now, how are we going to make it happen? And the biggest question comes, how is this going to happen so that it gets into a business? That is a nut to crack, and unfortunately we don't have a setup we can just copy, which we have it in so many other things, right? How we develop a drug and how we get paid, we know how to do that, but we don't know how to do something that requires people to engage, to continue the follow-ons, and so, and even some of these things, especially behavioral related, they can end up in a bias of the people who are using it are actually the ones who are more fit already or who are more healthy already because they care and they are already doing it. Right? So the question then becomes, how do I get to the rest? And it comes a bit back to like the access we were talking about, so there is some overlap on that. But what we would be looking for and trying to help think about it is, okay, what partnerships or or what creative ways we can get that traction.
Great. I would like to take some questions here from the audience, and go ahead.
I'd like to ask Michael to describe a little bit more about the platform for outpatient care.
Sure, happy to. So, more broadly speaking, the organization uses an electronic health record, as many health systems across this country are transitioning to or already have. Ours happens to be Epic, which is the majority of the market share. That's the actual EHR. In terms of the platform that we utilize for remote patient monitoring, that's a readily available, download it on the App Store right now if you'd like, company called Life365. We've been in partnership with them, and I believe in investment with them since 2020. They help to essentially allow us to even be in this space, because without them giving us a means for collecting the data, there could effectively be no RPM program. So they help to connect with the devices. We have a slightly unique tweak model, but they'll even provide and ship the devices directly to patients' homes once they've been established and there's been an order placed for them. And then the setup or the connectivity is essentially done remotely by their team if the patient needs any education on top of what the clinical team will do. And then we just start collecting data. There are dedicated folks to make sure that, usually non-clinical folks, that follow up to make sure that the requisite number of data points are in each month, just so that we can collect for certain what are known as CPT codes, so that the organization can be compensated. But it's very much a labor of love, a labor of quality, a labor of wanting better clinical outcomes for our patients and patient care.
And your focus is specifically on cardio?
It's really broad and diverse. What are the most common chronic conditions in folks, let's say north of 65, 70? They tend to be heart failure, COPD, diabetes, pneumonia. And so it's more of that's where the opportunity lied, not that we're intentionally self-limiting into that clinical area. It's also good because in that particular diagnosis, oftentimes your cardiologist almost ends up becoming your de facto primary care physician, and they end up managing a lot of your complex medication regimens. So by having connectivity, not that this is a prerequisite, but if someone's cardiologist is also a member of the organization, then there's much more free-flowing communication between our remote patient monitoring team and their cardiologist, who is effectively their primary. So there's no gaps in care. There's instant or near instant, at most maybe a 12-hour delay, and knowledge between data point that concerns us. Hey, Dr. So-and-so, I just want you to know that Mrs. Smith's systolic blood pressure is 170, or her weights have been increasing more than 2% over the last 3 days. Should we increase Lasix? Should we adjust this? Do we ask her to, I don't know, limit fluid intake, whatever the solution might be.
Thank you, Michael. I want to go back to a point that Sylvia made and just have Andrea and Merja respond to it, and then we'll come over for your question. The issue that Sylvia says, we have to be creative about partnerships. And I'd love to hear, Andrea, what you've done, because you have all these partnerships on the sickle cell disease side, and you have this vast 42-state network and blood. Can you just talk about the partnerships and how you see that impacting the work that you're doing?
So I think sickle cell is interesting. So at our core, we have the largest rare blood inventory in the world, and ideally providing precise match products for sickle cell patients. A sickle cell patient now, based on procedures, can receive 200 transfusions in 2 years because they're pre-transfusing them so that they don't go into crisis. So that's our core business, giving you the products to kind of keep you alive and out of crisis. Then we have researchers that are looking for the next cure for sickle cell, and then FDA was all over the news in the last couple of months, the new therapies that might come out that cost in excess of $1 million. And so how do you merge all these things together? Who can afford the $1 million treatment? I've also heard, I'm not a physician, disclosure, but once you have that new treatment, can you go back to receiving blood and blood products if it doesn't work for you? So we have partnerships all across the U.S. As well as our genomics lab looking for new rare antigens. We also, I just wanted to mention, there's interesting things that we do. We have access to 1 million healthy people, and that mini medical physical that we do when someone gives blood is a real window into their health. And so if you're a regular blood donor, you have 13 tests done. And so we've been looking at that. Not only do people come to us and say, can we look at your data? We're part of the REDS study that's going on across the U.S. But our healthy blood donors are also an opportunity. We're very protective of their data. I don't want to at all suggest that we give away their data, but adding extra questions to the process is very valuable to researchers and potential partnerships.
Super, thank you. Mirja, can you talk about how the partners that you have, you mentioned quite a number that are both referring and that you're also partnering with on the government side, and how that has impacted, what you're doing with the exercise clinic that you're running?
Since we are in a public system, we have the access to talk to everybody in the same healthcare area. So we have now these new well-being services counties in Finland. They were actually funded a year ago, so this is a totally new system. But for instance, I'm from the middle Finland area, which covers about 200,000 to 300,000 inhabitants. And the referrals from the same hospital come from other clinics and outpatient clinics, and I have been sending emails to the doctors that they can send to patients to us. I have given talks in their meetings, just personal talks with the doctors, everything what you can do. And we have increased the number of referrals from the hospital by 60% during the last year.
Okay.
Or this year, during this year. And then, of course, we can talk to the doctors and nurses in the local health centers, in student health care, or in occupational health care. So I give presentations to them. I try to get them known, that they know what we are doing, and we have been trying to spread this quite a lot. And for instance, last week I was talking in a big conference in Helsinki, and now we are starting to put the thing going on in the university hospital in Helsinki. Helsinki is the capital of Finland, and it's the biggest area in Finland, about 2 million people in the smaller area there. So, but of course they are not going to have only one exercise medicine clinic because they are too big. So they have to have like satellites in different hospitals and health centers, what they have there. And it's like a kind of a business, but we do it in using the governmental money. So that's a different thing.
Okay.
Yeah.
Thank you, Mirja. A question over here.
I'm sorry,
Pat McCarthy, and I'm an investor, so I come from that perspective. I also had a stroke, went to White Plains Hospital. I'm also in congestive heart failure. I've never heard of your program ever. Never been contacted by it. Just so you know, part of the issue seems to be, like, why is that somebody, clearly I did what they're doing in Helsinki, right? I did things to take care of myself. But why is it that, what would we change to create these, I know all the healthcare providers, trying to save healthcare dollars by imposing anticipations. But like in America, we have this issue with somebody's got to get paid. How do you have to just change the entire focus of the system to, Sylvia, how would you do that if you could rewrite the system? Right? You know, I mean, how would you, because you can have all these great ideas, and you can create all this data, but if you don't have kind of a system that incentivizes appropriate interactions in the right times, it's all just going to be a bunch of data flowing. Like you have your Life 360 or whatever. Nobody's ever contacted me. I could be a successful person for your group, but nobody's even thought of me. Well, why is that never happened? So, like, what would you change, Sylvia? Like, how would you rewrite the system so I was found? Right? And your data on sickle cells, I was found. You had all this data, but nobody really knows how to use it other than, say, a doctor, but then it might be too late. Right? So how do you get in front of all of this information and great products that you built to serve patients?
Okay, Pat, I'm turning over the moderation of this panel. What do we need to change to do this? Sylvia, yeah, and then we'll come over here. Thank you.
So it is a complex system, right? And I think it would be great if we have one silver bullet that would fix it. And I think there are several parts to fix before it would work for how we would like to work. And I'm also European, so I know how some of those other systems works, and sometimes we think they are better than they actually are over here. So I would preface that with it. So I think one thing is the incentive, for sure, right? So how we pay for things and what gets incentivized, because this is just how the world works. The money, you need to follow the money, and the incentive to do one thing or the other. So what is challenging is that some of these preventive things we don't see the benefit and the outcomes until later, right? And for us to see the benefit and then convert it into an economic benefit where people would be incentivized to pay for it is where we have ultimately the issue. So sure, having better ways to pay and codes and CPT codes, whether a big change during COVID was allowing to pay for telehealth, right? This has made a big difference. And this had been something that had been battled for years before it was actually passed and approved, and insurance began to pay for it. So that's clearly one component, but I also think that is not the only component. I have a gym in my building, and I have been there maybe twice in the whole year, right? Yes. I know it's bad. I don't need anybody to tell me that it's a bad idea, right? But it's not happening nevertheless. So that kind of incentive and adoption, we also, as generally people, we are not wired to be so preventive. And then I think like getting that as a culture, as an incentive, and so is also part of what we need to fix. I think things that integrate with where we are today are the most successful. So when we talk about, for example, diagnostics or preventive diagnostics, when they are an extra thing in the same blood panel that you normally do, that's easy. When you need to go to a special facility, get another exam, a different scan, well, that's more hard, right? So I think the opportunities for moving the needle are there where we can integrate to a certain extent with what it is and take advantage of things, use them in a different way that we can facilitate the movement and then push for these other bigger changes at the hospital level, at the payer level, at the insurance level. I'm sure you wanted something more concise.
Do we have a question here?
I've been listening to everything that you've been doing, but I don't hear anything that addresses the psychosocial of a person or the mental health of the person. And I think that's paramount to all what you're doing. I became acquainted with sickle cell 52 years ago when my nephew had a hypodermic needle stuck in his head because that was the treatment at the time. I was reintroduced to it last year when my great-granddaughter also now has sickle cell. So thinking back and looking on medical forms, there was never any question of, do you have sickle cell? Do you have sickle cell trait? So that was a lost opportunity in the medical field because I could have been one of those people that was in a test because I have sickle cell trait. I also have O positive blood. So I can donate to everybody, and I have this big possibility of having children with the disease. So communication, mental health is part of it, and we've dissected our body so much into so many components, we need to bring them back. So something, a company that can touch on the mental health of your clients could be something that you'd be part of that integration you're talking about.
Very interesting question. What do you think about that, Andrea? And then Mirja, I'd like to hear your thoughts too about the mental health adjuvant.
I think it's a very important consideration. And of course, we're a not-for-profit blood center. We're trying to provide the blood and blood products for the care. But it's also very important to us to partner with the sickle cell organizations on awareness. The New York City Council just passed a new bill to fund education and testing, because doctors don't even know how to address it. So in New York State, I believe they test all infants, but that doesn't take care of people moving to the state. So I agree with you, it's not within our scope, but we understand that that's a very important part of providing great care and improvements to folks' lives, and the medical community is not as educated as they should be, and I'm very happy about that bill. Even rare blood, many docs don't know. You just order blood from the blood bank. They don't realize, the sophistication of the rare blood inventory.
Mm-hmm. Thank you. Mirja, how are you handling the mental health side of treatment for people who have these diseases?
Yeah, for sure we try to talk with the patients about the mental health disorders and issues what they have. Most of them, overweight people, have depression or anxiety, and we try to talk and try to solve out why they have that kind of problems, and if they need more care, we will ask psychologists or psychiatrists to do it. But we also have quite a lot of referrals from psychiatry, patients with anxiety and depression and overweight. And they come to our clinic, or then of course there can be also underweight when you have psychiatric problems. So we really are aware of it, and we want to talk with the patients in an open way, but I think that the best way to help these people is to talk with them face to face. Face to face is always better than digital or phone or whatever. People need somebody to talk, and if the doctor or the special physical therapist or nurse would have time to listen, these people want to talk about their problems, and they will get better if somebody has time to listen and be present.
Wow, thank you. Well, this is an unbelievable conversation. I really appreciate everyone joining here today. Merja, thank you for staying up. You're, I don't know, 7 or 8 hours ahead of us. Andrea, thank you for joining. Michael, Sylvia. There's more questions, I know. Let's go and keep the conversation going, have some coffee. I want to invite Deborah Novick to come on up here and close us out here. Thank you. Really interesting conversation.
Thank you.
Thank you.
Yep. Bye-bye.
Bye-bye, Merja.
Thank you, Mary, and thank you to the panelists and everybody here in the audience for listening. It's such a gigantic topic. I mean, we've barely scratched the surface. I know there are questions in the audience. I have a million questions myself, and I don't want to commit us to a series of panel discussions on this topic, but I can imagine that we probably could have an ongoing series. There are so many unfamiliar faces in this audience, and I'm so happy to see you all here. As the Deputy County Executive and Amy both mentioned, the life sciences is a priority sector for us. Excuse me, Doris. And we have been holding events over the last several years to bring people together and learn from them what their needs are in the life sciences and health tech industry and how we at the Office of Economic Development might be helpful. But mostly I think convening is a big part of the solution, because as people get to know each other, collaborations hatch up naturally, and we don't have to force them. So if you're here and you don't know us and you don't know what we're doing and we don't know you and we don't know what you don't know what we're doing and we don't know what you're doing, I'd like to change that. I'd like to invite you to join our weekly mailing list or weekly newsletter where we talk about what's happening in the life sciences. I'd like to get you to come to more of our events, and I'd like to learn from you what your needs are and how we can be supportive of what you're doing. So thank you so much for being here. Looking forward to talking to you all outside.
Thank you very much. If you want to have another cup of coffee before you go back out, we know that it's a little bit cold out there, so maybe you would like that. We do have a survey for this event, and so if you want to put your cell phone up, you will be able to get the event on your cell phone. So we welcome that. We will have another event the end of January here that we're co-sponsoring with Westchester County on business incentives. So totally different than this, and part of what we want to hear from you is about your interest in having some more information about prevention. So thank you. Thanks very much, and please join us outside to meet some of the other very interesting people who have joined us here today. Thank you.